Okay, let the participants join. सिर्फ थोड़ा सा 15-20 seconds वेट करेंगे ताकि participants थोड़े से join कर लें and then we will begin. Okay. People have joined. Hello, everybody. Assalamu alaikum. I hope you all are doing well and great. Today we have Professor Dr. Riaz Ahmed Warraich. He is the oral and maxillofacial surgeon. He has a surgical experience of over 25 years. He is the pioneer in setting up one of the busiest maxillofacial facilities in Pakistan, in the Mayo Hospital, Lahore, and he helped get recognition for the field of oral and maxillofacial surgery in the country. He has various national and international publications in his name and continue to work for the betterment of his students, patients, and country. He has served as the chief executive of the largest public sector medical facility in the country, which is Pakistan Institute of Medical Sciences, PIMS, Islamabad, and the principal of the Nishtar Dental College, Multan. Today, the topic is the spectrum of oral and maxillofacial surgeries in Pakistan. So I would like to hand over to Dr. Riaz and he will proceed with the presentation.
Important thought. Here I am restoring the function first, and cosmesis will not be my that big priority at this moment. So these things should be clear to him. As far as expectations are concerned, so patients, whatever the expectations patient is having, one must there was a certain software programs in which you make a face and then tell you patient that you will be like this, and after that when you are not able to create that, then definitely patient will be upset. So that expectation should be met before you do some surgical work. Then obviously is willingness, and the most important thing, that is the compliance, that how he is in your follow-up after. So, uh, see pushing you towards be support slowly then time the internal fixation. Previously, we were doing wire osteosynthesis. We were only putting wires in the bones. But with the advent of evolved ourselves towards the internal fixation by surgical plates. So this is how we have gone up and up. And then, as we were more intelligent and more mature, then we have started taking a craniofacial surgical area as well. So in that particular field, we were doing cranial surgeries wherever there are fractures. You can see a patient where of missing part picture.
I'm sorry to interrupt you, sir. The voice is a bit not clear. If Dr. Abdullah, can you do it from your WhatsApp? I'll do the audio from WhatsApp and the video and presentation from the StreamYard.
Is it clear, sir?
Yes.
Is it okay now?
Yes.
So we are ready. Well, what we have done the mesplasty ptosis is recovering. And
Yes, sir. I'll make it clear. Just give me a second. Yes.
So, what I was talking about this patient, over here we have done mastoplasty, and we have repaired this bar and clear out the nerves, in orbital nerves, which were supporting the orbital muscles, and then we have corrected the ptosis as well. This is the patient now is recovering from ptosis as well. So next. Again, this is a young boy having craniofacial injuries, and the ptosis was declared as a permanent ptosis. But when I have seen this patient, I have seen the frontal bar is just pushing the lid downward, so it could be a pseudotosis, it could not be a true ptosis. And we have repaired it, and you can see the results, the ptosis is over. So my message in this particular case is that sometime you misdiagnose the patient. So take care of your diagnosis properly, then you will be successful in doing cases. Again, if you see this picture, this is in fact a young child fall from tree, and this peg has gone through and through. If you see this scan, this is the peg going from one side to the other side and injuring bilateral way of life, and when you are working on a gateway of life, you must know about the anatomical structure properly. So again, I have operated a series of cases like this. If you can see a X-ray of this, so it is showing just like sunburst appearance and looking like an osteogenic sarcoma. But you will be astonished to know this is not an osteogenic sarcoma. It's a gigantiform ameloblastoma, and this is the enamel structure which you see like a sunburst appearance. And you can see the tumor size enormously, it has grown. And now major challenge was resection and then reconstruction. So in reconstruction, I have just cut short because the time will be limited. Reconstruction, we previously planned like we will take fibula and put on a mandible, but when we have just seen his both legs were injured by bullets because he was a frequent border crosser, and then he was caught by the agencies, and he has developed this lead and brought it to me. And we have overcome the challenge through raising, this is the sternum based on the pectoralis major muscle. And I have the credit to do 4 cases in my career, because world over in literature only 2-3 cases are available where the sternum transfer was there. So we have done it. The sternum transfer is showing that inconspicuous scar. There is no big scar. This is 3 years after photograph, and he is doing very well. So that was really a challenge which I have overcome in that particular case. This is a patient from Amritsar, India. So my next case, it is this young female was from Afghanistan, and you just see the scan. This is a huge destruction everywhere, and bony formation is there. Again, this is a gigantiform ameloblastoma, nothing else. So you just see the tumor size, but we have accepted a challenge, and we have done in our hospital. This is immediate post-op picture. Within 1 week, we have reconstructed her with the fibula, and after 4 years, she has this exposed plate over here, and then she came back to us for this, and then we have removed and then repaired it. And you can see this dip over here, but this was our fault because we have to put a filler inside. This flap has gone inside, and by that there was a pressure on plate, and that was exposed. So in the next case, this is, so sorry, the haphazard slides are there now. This is again a gigantiform ameloblastoma, and this patient I have received from Sri Lanka. You see the tumor size, and on scan again bone formation. Again, this is a gigantiform ameloblastoma. So I just wanted to show my students that sometimes you stuck in these diagnoses. Please take care and take a good biopsy, and ultimate diagnosis you reach, and then you will be successful in surgical work. So we diagnosed, and then we plan for reconstruction. And this is how we reconstructed. Here you see this flap we have used. In previous slide you have seen we have done a mistake for which we have not used a filler, but the extra skin we deepithelized this much, and then we have tucked in. That will act as a filler, as you see in a final closure in that. This is the fibula which we have taken, and in situ we have done osteotomy on a pre-banded plate. Still the vascular pedal is along with it to lessen the ischemic time. So we have then transferred here and reconstructed here of this poor lady. Next. This patient was again received from Indonesia. He is an Indonesian patient, and we have taken a fibula and then transferred here. So here you see a black spot. So this I wanted to show is because the vasculars, all anastomotic surgeon knew about it, that invariably vein create a problem. It blocked, and then there'll be a congestion in flap, and flap lost. So I have reopened it, and then I re-anastomosed, again failed. Then again re-anastomosed, again failed. Then I did this procedure. That this is the leech, which you can see a black area. I have put my residents' duty over there. They were putting leeches, and they are sucking the venous blood. They don't suck arterial blood. Deoxygenated blood they suck So 1 week we put these leeches on, and we have saved this graft. And this is, you see, post-operative, almost the 3 years after he came back to show me. This is the post-operative picture of the same patient with a perfect bone graft over there. Please tell him. Sorry, this is again a slide which we were just skipped because it was series of we have just put together, but unfortunately when we have loaded it, so it was just haphazard. So this patient has the fibrosarcoma. So that, it was again a challenge, not a removal, but reconstructive challenge was there. She's a poor lady having 4 kids and came to me with a great hope. Then we have accepted this challenge, and then we have resected, put a metallic plate over there and joint attached joint with it. And then we have raised 2 flaps. One is latissimus dorsi, because pec major, a young lady, we were not intended to spoil her breast. So we have taken the latissimus dorsi muscle from back, and then we have reconstructed. Final repair we have not done still, because we will have to wait for the radiotherapy and any recurrence on it. Then we will be doing final repair and cosmetic, creating a good cosmetic results. Next. So again, a young boy having a joint cell tumor in the center, where mandible, this is for the young students, then where mandible takes a turn, and their free graft, I mean to say a free iliac graft without a vascular supply will not be successful. So you have to put some vascularized graft. So we have just resected it. You can see the intraoral tumor size, and then we have reconstructed with the fibular graft. So we have put a fibula. You see the contours, and intraoral healing is very good because it is all vascularized flat. Again, dear students, this was I have just put those cases which pose a great challenge to me, and maybe everyone, everywhere, people have the challenges like this. This young boy is a final year engineering student, and previously 3-4 times operated upon. You can see the scar on it. This was really a misdiagnosed tumor. It was in seminoma. Seminoma, that is the germinal cell tumor. And the major problem is here you see the greater vessel you cannot see. When we have taken a Doppler, they have shown us that the greater vessels are intact. But when I gone in, the even internal carotid artery was blocked with the tumor. It was totally clogged. So, dear students, in fact, if you will have to clamp the carotid artery and transpose it, you will have to see the circle of patency of circle of Willis. But at that moment, we were missed that investigation. But there and then there was no option to transport the internal carotid to the external carotid, because external carotid were intact. So what I did in this case, I have just resected that part of internal carotid artery and then transposed and anastomosed with the external carotid artery, and this is the post-operative result of the same boy. He's doing well now. And again, it was a young doctor, and this was a thyroclossal cyst, and you can see on the scan, it is just attached with the larynx. Well, that was the big challenge. Nobody was accepting him because he's a doctor and very young, and if you open a larynx, that will be another problem. There is a recurrent laryngeal nerve which is entering at this place. That is also at risk. And again, obviously, the cosmesis also matters. So I took over this challenge, and then I have just removed this. I did a cyst trunk operation. Everyone knows about the cyst trunk operation, and then repaired it. And you can see a very minute scar over there, and he's very happy. There is nothing, no function lost. Lee-Fromenai syndrome is very rare, but but wherever it is a very destructive sort of a syndrome. This leaf-from-an-eye syndrome world over, I think I am the luckiest person to have 3-4 cases of leaf-from-an-eye syndrome. Nowhere in the world, only in Italy there was 3 cases operated upon. But in this, there must be 3 tumors to come. One is rhabdomyosarcoma, which comes in early life, like when a kid is about 6 to 7 months old, and then osteogenic sarcoma that comes in 6 to 10 years of age, and then fibrosarcoma, which comes after 12. So all 3 tumors has to come. Look at the size of the tumor. Almost half dead patient was taken to me. Previously, one of my colleagues has operated upon only doing misdiagnosed case. So it was just the broken down plates and everything. If you see this scar on a thigh, the patient has been operated in 6 months of age for rhabdomyosarcoma. So again, I'm saying you that one has to diagnose before it being operated upon. So I have diagnosed that this rhabdomyosarcoma is there, so it was operated upon. So it is a leaf-from-an-eye syndrome. So third tumor will have to come after even surgery. So I have done a surgery on him. So this was how I did it, and then repaired it with the pec major muscle. But I have waited for the third tumor to come before any reveal. So this was, here you see, this is a fibrosarcoma. We have taken biopsy, and child is 13 and a half years. So fibrosarcoma has come. So then we are now going to operate upon him as a fibrosarcoma, and then we will do a final repair and cosmetic sort of approach. Again, a second case of leaf-from-an-eye syndrome. You see a huge rhabdomyosarcoma on thigh operated upon in a 9 month of age, and then came to me in 9 year of age. You just see intraorally, but unfortunately, if you see the chest X-ray, a cannonball appearance, the metastasizing in the chest, but it was pushed that we must operate upon, and the oncologist told me that I'll just burn out this spot in the lung. Then we have operated upon, and this is how we have removed, and pec major was given to him, and this is a recent picture of him after surgery. Now he is going for chemotherapy for the lung lesion. Next. Again, this has been referred from a tertiary care hospital to me. This is angiofibroma, nasopharyngeal angiofibroma. As you know, this is a very dangerous tumor, and the bilateral ptosis was there. There was no vision in both of eyes, and if you see a scan, the tumor has gone inside and putting a pressure on optic chiasma, and child was blind on both sides. And the ptosis was also there because it has compressed the orbital contents as well from back side. So what I did is, this is a down fracturing of the maxilla, and I have gone into the base of skull and taken this tumor out. You just see a picture 1 week post-operative. The pack is still sinus pack into the nose, but ptosis gone. Both eyes are open. One eye is totally clear and vision, and the other eye was recovering. So now, yesterday, 2 weeks before, sorry, I have seen him. Both eyes are perfect, and vision is back. So he is doing very well. Next. Again, this was a very challenging case everywhere. He was being refused. Again, it was a nasopharyngeal angiofibroma coming out of nose. Look at the vascularity through MRA and the area involved by the tumor. So here the most major challenge was we can create the permanent ptosis of the eye. That was the bigger issue to solve. So why did I have lateral anatomy approach and taken the nose up, maxilla on side, and then I have taken this tumor out. And this is the post-operative picture of the same boy. Nose is all right, no issue, and there is no ptosis, only partial ptosis, and it is recovering. and he is doing very well. We have operated a series of cases and reconstructed the radial forearm flap. This is the radial forearm flap. Dear students, as you know, it has been based on the radial artery and cephalic vein. We have we have our credit in Head and Neck Oncology Journal, which is a very renowned international journal as well. And we have put up almost 100 cases in this study as well. Look at the mouth opening, legible speech, everything going very fine after resection and reconstruction with radial forearm. Next. This is another case. This is after 6 years of post-surgery, half of the tongue has been reconstructed. You see mouth opening, function, everything very well, and even unrecognized area of reconstruction. It is mucosalized and the flap is looking like the original tongue. Next. Here I have just put one case because when I operated upon, put a radial forearm flap here. So this happened. I was not in a country and I received call to call, and there is a huge leukoplakia on it, and again cancer ho jayega, this, that. But when I saw a picture, I advised them that have a soft brush and brushed on this slab, and you just see there is no leukoplakia. This was also misdiagnosed. It is just a keratin. The out product of the skin is keratin, and we have taken a skin from radial forearm and put over there. So this was the keratin when we have just cleaned it, and it was cleaned. There was no cancer. Received from Saudi Arabia, composite resection, mandible, outer mucosa, and large pedal of skin we have taken along. So here I raised a rectus abdominis muscle based on inferior epigastric artery, and this is how we have reconstructed. If the one of its area has gone inside and reconstructed the mucosal area, this is the skin area, and putting a plate for the mandibular reconstruction. This is post-radiation. The flap is doing very well. There is no necrosis, no opening. Next. Dear students, I just added this case just to give you one of the message that the parents are the most important entity in your life, because they have raised you, they have looked after you, but then when they get old, please look after them. Look at, she has 3 young kids and they are big officers. One is the ambassador of Pakistan and one of the country, I don't want to mention the name, but she was ignored, put in one flat with one servant, and she had a BCC, and BCC has eaten her away. There is no nose, no upper lip, no eye, nothing there, you see, and partial lower lip is also eaten away. So CT scan, you just see, and this is the resected area, no eye, no nose, no half of the lower lip, and almost total upper lip gone. So challenge was how to reconstruct and how to rehabilitate her. But I have just requested them that we will not accept this, because this will be the challenge how to reconstruct her. But they have pushed. One of the NGO has pushed me to do that. We have taken this challenge next. Here again, we have raised a rectus abdominal flap. This is the inferior epigastric artery. Based on that, and this is for lip, and this is for nose and cheek. We have put over there, and you see flap is surviving. She is still on oxygen, and but when she recovered, she didn't allow us to make a cheek and lip and nose. But she didn't allow us to have a photograph. She allowed us only to show these, to give the message to the public that this should not happen with the parents. She is living very well, mashallah, and doing very well. Again, dear students, you may receive people like this. This was a BCC, and that was basically a basosquamous carcinoma. Eaten away everything. You can see the area of resection, half of the nose, lower lip, upper lip, and reconstruction challenge was here as well. Then next, here we have raised two flaps. One is the radial forearm, and other is this is the median forehead flap, which has made a nose, and this radial forearm has made the cheek, upper lip, lower lip, and the facial area skin as well. Next, so this is the post-operative picture after 3 weeks. He is almost doing well. Nose has been reconstructed in a reasonable way, and there is a good seal, and he is very happy. He is eating and enjoying his life. This case I have added purposefully. I have operated in Bangladesh. I went there to have take an exam of their fellowship, and there they have just put this case as an examination case. But it was a fibrosarcoma of a young girl. And I asked that to the head of the department that what will you do for her? He told me that we can't operate her. We are just referring to the oncology. But I told them I have 2 days before, 2 days and a flight. If you can arrange, I can operate upon. So this is how we have operated. They have sent me the post-operative picture. She is surviving. But the message here was, I have told them that at least 1 liter of blood will be housed in this tumor, and when I'll resect the acute loss of about half of a liter or a liter, the patient will collapse. So they have told me that the blood is arranged, no issue. But when I have resected and taken the tumor out, 3 brannulas were put in, but there was no blood. They have not arranged any blood at that moment. So dear student, what I did is, I am a B negative blood. One of the nurse was B negative, dewashed and given a blood, and type blood we have given her. There was no cross match. And this is allowed at that moment when you are saving the life, because you can control any allergic reactions, but you cannot control the death, So cross-matched blood, untyped cross-matched blood should not be given. Typed uncross-matched blood is allowed to give. Next. So this was the cheater team with me. These are all Bengalis standing with me, who they have not arranged the blood at that moment. Purposefully, I added them and just show them. So my message over here is that you see each and everything before you go for surgery. Only one mistake I have done, I have just believed them that there is a blood and I have been caught there. Again, a very rare lesion. If you see the scan, the greater vessels are under this. And the other thing is, previously you see a scar 3-4 times operated upon. This is a dermatofibrosarcoma protuberans. It's also a very rare lesion. It runs in the dermis, and it's a very aggressive lesion. And you can see the size. So we have took the challenge, taken the challenge, resected. And you see these lines, these are purposefully made because I have divided the area into zones. So taken the frozen sections from each zone to confirm whether tumor is there or not. So then whenever we have confirmed, you see total pyrorectomy done, variabilictomy done, and this all area skin has gone. So over here I planned a anterolateral thigh flap based on the circumflex artery branch. This is that, and we have taken out. And this is the reconstructed area. I just call it a chitter flap. Chitter in our area, is a big shoe. So that is called the chitter. So this is the largest flap I have ever taken and put on a patient. This was. Next. This is, you see, pre-op. This is the post-operative picture after radiation and everything. He is doing very well. Again, a lesion is IgG4 solidinitis, previously operated by somebody, exposed area. Lesion was not healed. I have done a radial forearm flap, but diagnosed properly that it is an IgG4 solidinitis. That is an autoimmune disease. So by this experience, you see another patient was benefited. This is again a patient of IgG4 solidinitis. We have not operated upon him, and we have put on a steroid. And this is the post picture of this, because he has totally recovered from this disease. So dear students, always have a proper diagnosis to treat. You see, you do not run a knife on every patient. First diagnose, then go ahead. That's what I wanted to tell you next. Uh, this is again a very dangerous condition, that is a chemotechtoma, the carotid body tumor. Dear students, if you see this is present inside, the bifurcation, because there is the chemoreceptors are around, and there it divides itself. It has eaten away the external carotid artery and partially damaged the internal carotid artery. So nobody was operating upon him, because they say that whenever we ligate the internal carotid artery, you will be dead. So this was the tumor which I have resected. Here you see, this is common carotid artery and this is external carotid artery. So I have taken the wedge out and then anastomosis. Here you can see anastomosis, you see, and this is post-operative picture of the same person. He is alive and everything fine. Here, another major threat is 5 cranial nerves are just going through it: the glossopharyngeal, the vagus, the spinal sensory nerve, the facial, the hypoglossal. All these nerves are under threat. So you'll have to take care of them as well. So this is why this tumor is very dangerous. Next. So sorry, this comes after that. You see, this is the angiogram of the same patient, and here you see the internal the external carotid is almost eaten away, the wall of external carotid, and the internal carotid was here dented, and the tumor emboli was gone almost inside. So it was resected and then repaired. This is it was a type 3. It was a type 3 tumor. This is the classification in which both internal external carotid arteries are hit. Over here, vagus nerve we have saved. That is also a very important structure. Again, we have received a half dead patient. You see here in this radiograph, you see the huge tumor sitting on the respiratory tract, on a larynx. It's a soft tissue joint cell tumor. It's very rare tumor. It's joint cell tumor always in a bone, but sometimes it also occurs in the soft tissue. You see, there was stridor, and patient was almost not breathing well. Next. So here the challenge was the opening of the larynx and pharynx. How to repair it? Here you see, this is the opening you can see, which I have just shown. A hyoid bone gone, everything gone. What I did is I taken the sternocleidomastoid, wrapped around over here, repaired this, and the infrahyoid, suprahyoid muscles were stitched with the sternocleidomastoid, and sternocleidomastoid acted as a hyoid bone over there. This is the size of tumor you can see. And next, and this was the post-operative patient. You see, he is doing very well. Respiratory tract was intact. We have taken the nasotracheal tube after 3 days, and then he was swallowing very well. We have taken after 7 days, we have taken the nasal tube, feeding tube out. So he is fine now. Ladies and gentlemen, we have also many cases like this in our part of the world, in the early age TMJ encloses. Look at the bird face, and they are very poor people. You see, we have released the encloses next. Then we have put the distraction, because smaller mandible you cannot do osteotomies, sagittal split osteotomies next. And these are the serial picture of the similar girl, and now she is quite a presentable girl, in fact. This is the lateral profile picture of the same girl. And this is again was a challenging case, the Mobius syndrome. Bilateral facial nerve was missing. And what we have done, you can see a dimple here. You see bilateral dynamic fascial sling I have put before, and the sling on the eyes as well, and gold weight was also put. And then I have taken for the sagittal split osteotomy. Next, this is a pre-op photograph, and this is the post-op photograph of the same girl. There's a hell of a change. And she is married at the moment, enjoying her life. Tassier 3 Tessier cleft is a very rare cleft. You can see medial canthus is reversed. You see, it is totally down. Another cleft has just melted away the eyeball, and then cleft was going into the maxilla. If on STL model you see maxilla as collapsed, there is no bone in facial area, no zygomatic, partial zygomatic missing as well, gone up to the skull base. Next. So this was the STL model and workup. Next. And this is how we have put up bone grafts wherever the bone was missing. Next. And this is the bone grafts. Next. And this is closure. Next. This is the immediate post-op, but still many things are left because you see we have done a canthopexy. We have taken the cancers from here up to there and from here to there as well. Next. You see, we have put an artificial ball inside. Now he has a presentable face, but still one ravine is left as far as lip is concerned. And this eye we will take more closer to the nose. So equal eyes, both sides should be there. At this moment, he is quite presentable and doing his studies in a college as well. Next. I think this is the last case I have put for a message. You just see this poor girl. You cannot see a face, only a smaller area of face you see. This is the retinoblastoma. You know, it's developed from the eye, and ignorance is the heightened ignorance is there, and the parts of the parents as well. Look at the tumor size, which is the child is just taking along it. So they have taken to me, and I have accepted the challenge because they have told me that nobody is going to operate upon, everybody refuses. So this is the resected area. You see the hole in the arbor. We have taken a few pieces of the dura as well and put a fibrin glue over there, sealed it, and this is post-operative healing. Now we are just going to put an implants and then put a eye prosthesis over there, and then she will be inshallah presentable. Thank you so very much. I have taken much time for a few people. I hope I will be able to convey the message to you people that what we are doing and what should one do. And this is just, I wanted to inspire my younger generation to come in this particular surgery. And you know, in our part of the country, in the Southeast Asia is hit with the squamous cell carcinoma, and WHO has given us the epidemic alert till 2030. It could be an epidemic as far as squamous cell carcinoma of oral cavity is concerned. So here we have we are introducing another fellowship of which is FCPS of Oral and Maxillofacial Surgical Oncology. The people will be trained in surgical resection of tumor and reconstruction as well. So any question, I am there to answer you. Thank you so very much.
Okay. Can you hear me, sir? Okay. Okay, sir. Thank you so much for all the presentation and all the explanation. We are very happy to have you, and thank you so much for accepting the invitation from the International Association of Dental Students. And we are highly thankful for your time and for all the valuable information that you have provided us on this platform. Sir, any 3 advices that you would like to give to all the dental students in order to succeed in their careers?
My advice and message to our dental students is, whatever the branch of dentistry you adopt, you follow the ethics. The medical ethics are very important, very important. God Almighty Allah has promised us for the ruzi and for economic purposes. If you do work in a proper way, then ruzi will come to you, inshallah. But ethics are very important to adhere with. So in this particular thing, I wanted to add one more thing, that the integrated modular teaching should be there everywhere. And most of the country has adopted. My country is in a process to adopt the integrated modular teaching, because when my students from first year to final year, when they reach to the final year, they forgot all anatomical, physiological, pathological, and pharmacological aspects of the diseases. So when integrated teaching will be there, so then it will be continuous way of reminding you and repeating the things, so that you should be able to have a proper knowledge into it. And the last word I wanted to say you, that there is a very good saying, that eyes do not see which brain does not know. आंखें तो सिर्फ आपकी एक इमेज देती है ब्रेन को, तो ब्रेन will what it is. So if you have knowledge inside, you have skill inside the brain, that is will see. So that is my last message.
Okay, sir. Thank you so much for these words. Thank you so much for these advices. I hope most of the dental students that are fan of your surgeries and your knowledge, they would follow all the advices that you have given. With this, we would like to end our session. And if anyone has any question or anything, he can just write in the comment. We will wait for like 1 to 2 minutes, and then we will end the broadcast.
Technical problem might be has not listened properly. We are very sorry for those who were not able to listen us.
Like 20-25 people have listened. Like we started a bit late, but anyway, sorry for the inconvenience, people. And thank you so much for everyone who has listened the lecture. Thank you so much everyone for your time. And with this, we would like to end our broadcast. Thank you so much, everyone.
Pay my regard to the